Still have some more people popping in. Give me just 1 minute. Excellent. Okay, great. Well, welcome everyone. My name is Jen Anderson and I am the CHAMPS Clinical Quality Improvement Director. I'm your moderator for today's event. Community Health Association of Mountain Plains States, or CHAMPS, is the Region VIII Primary Care Association. We provide technical assistance to community health centers in Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. And I am very happy to welcome you to the third session in our Maternal Health Summit today, Primary Care and Public Health Collaboration, Integrating Title V and Community Partnerships. And if you've been to my last couple of sessions, you know that we have a wide variety of participants from agencies all across the maternal health ecosystem with us today. And because of that, I'm going to ask each of you to please take a moment to rename yourself. We would love to have your name, organization, and state. You can do so by clicking the ellipse on the top right-hand corner of your image. If you have any trouble with that whatsoever, please do reach out to Haley Donahue, labeled as Tech Help, in the chat, and she can get you renamed. As in our previous sessions, your feedback and contributions are a really important part of this summit, and this session in particular is going to have lots of great discussion. So I hope that you will add your questions and contributions to our discussion today, either in the chat, or do feel free to raise your hand, and we should have enough time to hear from you, and that'd be great. This session is being recorded for future reference. If you need technical assistance at any time during this event, please message Haley, who's labeled Tech Help. And if you are able, we would love to have people be on camera during the discussion session to really make sure it feels like more of a natural session, a natural setting, but we understand if you're not able to do so. As in our previous session, Dr. Sharon Tallboys, Associate Professor in the Division of Public Health at the University of Utah, will serve as our facilitator for our discussion today. And we will be joined by Darcy Lee, Director of Clinical Operations at Horizon Health in South Dakota, and Hope Klein, Office of Lifespan Health Administrator for the South Dakota Department of Health. Dr. Tallboys will further introduce our panelists today, and you can also read their full bios included in today's handouts. If you have not done so already, you can download them from the chat, and this document also includes the slide deck for future reference. And finally, I'll just add that the views and opinions expressed throughout the summit are solely those of the speaker and panelists based on their personal expertise and not necessarily those of CHAMPS. And with that, I would love to turn it over to Dr. Tallboys to get us started today.
Good morning, everyone, and welcome. Thank you, Jen, for that nice introduction. Today's session, we're going to be talking about something that I love to talk about, opportunities for collaboration between public health and primary care. We have two panelists today who are here to share their expertise on this issue, and we'll have time for discussion with you all. So please keep the chat lively, and there'll be time for Q&A at the end as well. And raise your hand. We'll be monitoring the chat and would be happy to hear from you as your questions come up. Our first speaker on the panel today is Darcy Lee. Darcy is an RN and serves as the Director of Clinical Operations at Horizon Health and has been with the organization in various clinic and leadership positions for almost 8 years. In her current role, she oversees the clinical support, care coordination, and quality teams and leads key clinical initiatives such as the HRSA Maternal Health Quality Improvement Project. So we're super excited to hear about that from the primary care setting standpoint. And then we have Hope Klein, our second speaker, is an administrator in the Office of Lifespan Health with the South Dakota Department of Health. In her role, Hope oversees programs and initiatives that promote health and well-being across all stages of life, with a focus on maternal and child health populations. She has worked in a variety of roles throughout her career, including with the Community Health Education Outreach, with the SDSU Extension, Title X Family Planning Program, and where she played a role in supporting reproductive health services. And today, Hope continues to champion maternal health collaborative efforts and innovative projects to better health for all South Dakotans. So join me in a warm welcome for Darcy and Hope. And I wanted to first share, if you weren't in the first session, it is in the handouts, but we have published a environmental scan preliminary findings from some of the work we've been doing to assess the environment for maternal health across Region VIII. And one of the key topics that's discussed in that report is public health and primary care collaboration. Before we hear from our speakers, just a quick note, I want to offer a little background to frame our session, starting with which public health we talk about that as the science and art of preventing disease, prolonging life, and promoting health through organized efforts of society, with the core functions of public health focusing on assessment of population health and well-being, policy development, which includes informing and educating the public, developing health supportive policies, and assurance, assuring that people can access health and live in safe communities. On the primary care side, which is completely complementary, primary care is a community-based service, often described as including these 5 core characteristics, as you see here. Often the first contact to accessing healthcare for people and their families. They're focused on continuity of care and comprehensiveness across the lifespan, and they provide important care coordination so patients can navigate our complex health system. And ultimately, we know that they're very patient-centered. Okay. And I'm just going to share this framework as we think about what does it mean to collaborate? What is collaboration? And just here you can see in this kind of framework, we can see that while primary care focuses on individuals and public health focuses on populations, there's a continuum. Not that we have to have a unitary agency, but I think we'll see lots of opportunities today in our discussion that span from overlapping activities through cooperation and collaborative activities. So that's the topic for today. And I'm going to jump in first and introduce, and we'll jump in and hear from Darcy.
Yeah. Thanks everybody for having Hope and I looking forward to this conversation. I think it's going to be a good one. Um, yeah, so we were awarded the HRSA QIF quality improvement funding from 2023 to 2025, and which was a pretty big project. I actually was on maternity leave. I didn't even know we applied for it. About 5 days later, I got this position and also the maternal health grant. So learned a lot very quickly with this grant. This grant works differently, or so I'm told, from other grants because it was like a giant PDSA, which was kind of fun, but also a little scary too. So they really wanted us to like figure out what worked, play around with things, and report back so that that data and feedback could be shared with others across the nation. There were about like 33, 36 other FQHCs that were also awarded this funding. So our main initiatives, patient feedback, we can't improve on what we don't know, what isn't working or where the gaps are. And so we did a lot of patient surveys, focus groups, one-on-one interviews with our pregnant postpartum moms, those who had miscarriage, like the whole assortment. To try and see, all right, this is their biggest priorities, and are we meeting those needs? And if not, how can we improve? We wanted to increase our outreach and marketing for services, so radio ads, commercials, more marketing, because the sites that were in our maternal health grant, not all of our sites, there's 4 of them, but our main one is in the largest maternal health desert in South Dakota, has extremely high maternal mortality rates. It's on a reservation, a large patient population that really struggle with basic needs and healthcare. And so we wanted to outreach and market so that they understood they could still receive their low risk prenatal services at our clinic. We will collaborate with their OB provider, and then we can do their postpartum care right at home, because a lot of people didn't even know we could provide those services. The biggest focus of our grant was providing care coordination support. Really, it was kind of handled at the care team level, but they're so busy, had such high staffing turnover. We really wanted one main person to work directly with those patients and be that main contact for all the teams involved. And that would mean increase in collaboration at local, regional, and state areas. Increase our collaboration with delivering facilities. There was a lot of duplicate services regarding lab work and referrals and things like that. We wanted to get better at communicating what we had done and what they had done. We wanted to increase our first trimester visits. Most of our patients presented late to care, which already made them high risk. And we wanted to increase our postpartum and newborn visits. Most of the time, postpartum, they would come back, they were already pregnant with their next child. So we don't have accurate data on what we were running for postpartum visits, but it was less than 10% is what we were estimating, and you'll see that later on in a couple of slides. We also wanted to streamline education materials across the org. We kind of had providers using whatever resources that they wanted or that they felt were important. So we streamlined our internal education to providers. We streamlined the platform that we used for patients and the education materials that came along with that. We wanted to focus on some teen pregnancy prevention. We didn't get very far with that. South Dakota is kind of a tough state when it comes to navigating teen pregnancy and education and collaborating with the schools. So we didn't get very far in that, unfortunately, but we did set up what we call a baby boutique, otherwise known as mHelp. It's the Maternal Health Earn and Learn program. And so if the mom went to school or attended prenatal classes, came to their prenatal appointments, came back for a postpartum visit, they would accumulate points that could be used to, I don't want to say purchase, but to get awarded supplies at our baby boutique, whether that was a stroller, clothes, bottles, things like that. So that really got going towards the end of the grant. We actually got an extension to try and like kind of tie up all the loose ends around it. So we were able to extend our funding for a couple months focusing on that. And then we also, Horizon Health, FQHC, we also have dental and BH service lines. And so we did a few smaller collaborative initiatives surrounding maternal health. So I'll talk about that in a little bit. Next slide. On top of all those big initiatives, the big goals of the grant, we did a lot of smaller projects. And so, small project, a big impact, because even though it was small, it could have very well taken 10 months to actually achieve and meet those goals. So, partnered with the state for safe sleeping initiatives, so pack and play distribution. Also partnered with the state for car seat distribution. So we get car seats from the state, and then parents go through an education, and then they can install the car seats in their vehicles. We were going to do certified installation training for our staff, and that was extremely difficult to come by. And so what we were able to do was provide the education so that they can check that a car seat was installed by the parent or guardian correctly. We can't actually install because of liability issues, but we were able to provide that training. Increased our collaboration with WIC and Bright Start in those main regions. We brought in the mobile sim unit, and so we had a local labor and delivery unit close their doors, and it really stressed out our staff. Everybody was very concerned that we would have pregnant patients coming to the clinic to deliver because there is no other access in that area. And so we provided the mobile sim unit to come on site and go through precipitous deliveries, hemorrhaging, eclampsia, all those. Even though we're not a delivering facility, they really appreciated that extra level of support and training for those emergency situations. Continued collaboration with OBs and delivering facility teams, and we had to extend that across state lines. One of our major delivering facilities is now in Nebraska because that local one closed their doors, and just even getting medical records back and forth is a challenge across state lines. So keeping that line of communication open was huge for us. Continued community and state outreach efforts. Once people started hearing that we had this maternal health grant, it really opened the doors to, well, what are you doing? What are we doing? And how can we partner instead of compete? We brought our behavioral health team and our primary care teams in for maternal mental health certificate training. That was a 6-month training, and just really dove into that education, screening education, and referral process for pregnant and postpartum individuals. And then we also partnered with Delta Dental. So one of our dental teams we were able to use the Delta Dental bus, and they parked right outside of our medical clinic in a location where we don't have dental. And we were able to provide cleanings and preventative exams for pregnant moms, postpartum moms, and their significant others or kids. And so we had wanted to do that a couple different times, but scheduling was an issue. But we did have a really successful day with that. So we tried to incorporate it with our other service lines. Yep, go ahead. Next slide. Yep, so here's just a picture of our sim training that came in. All the staff really enjoyed it. Next slide. And then car seat inspection training. So we had those that attended were community health workers, some of our main OB, I don't want to say OB nurses, but the nurses that work primarily with our prenatal patients, some of the providers and front desk, or our site coordinators, what we call kind of a lead in the clinic, and they are all able to check that a car seat has been installed correctly and then can loan out the car seat from the state. Next slide. So a little bit more information about the grant. These are our project-specific measures that we wanted to track and submit for HRSA. And so just a little level set here. The yellow bar is the most important one. That was when we had hired our maternal health care coordinator. She was a nurse. She worked remotely, and then one day a week was on site in our mission clinic, which was our primary clinic of focus. And so you can really see that yellow line is when we started to increase some of the initiative implementation and started to make an impact. The red line, that was the first half or first 6 months of the grant. Blue line, second 6 months of the grant, and that's when we had hired the care coordinator. So it took a little bit to get everything kind of in place. Our most important ones that we felt were like our biggest achievements with this are prenatal visits in first trimester increased. We had a little bit of drop in that last 6 months with some staffing turnover. And then patients who choose breastfeeding, our care coordinator is also a licensed lactation consultant. And so that really helped to supplement that education and support for those patients. You can see that we had two empty initiatives, prenatal visits with telehealth and prenatal patients using remote patient monitoring. We really struggled connecting with other organizations and getting their buy-in to doing those visits telemed. Horizon Health, we are very virtual. We're all over the state. We do a lot through telemed. Our entire behavioral health team is remote. Everything is telemed for them. It's not new to us, but it can be difficult to get the specialists on board for some of those visits. And so we struggled there. We also struggled using remote patient monitoring for the same reason. The local or their delivering provider, their OB, they really wanted to manage that at their level and not have that be collaborated with on the primary care side of things. But I still hold out hope that that will come in the future. Next slide. And then these are the grant core measures. So every FQHC that received this funding had to submit results on these measures. And this was Horizon's results that we submitted. And so again, that yellow line, that is when we had our maternal health care coordinator working full time and really implementing all the initiatives we had set out to do. And the three that come up as, I don't want to say most important to me, but what really stood out to me was that health risks, HRSN, I just lost it, but it's essentially the social determinants of health screening. We use the Prepare. We had never used it before. And so we've slowly started to implement that. And so you can really see that increase with using Prepare and connecting those patients to services. Our postpartum care, like I said at the beginning, we were seeing less than 10% of postpartum visits. And usually they were pregnant when they came back to the clinic for that visit anyway. So just to essentially go from 0 to I think it's almost 60%, which was a huge increase for us. And then the community engagement self-assessment. This is a survey that I completed every 6 months throughout the grant period, and it talked about collaboration at the local, regional, and state level, and how some of the activities were going. And so that was like like a scorecard that I filled out, and then I never cheated. I never looked back to see what I scored last time. So it was always a blank slate, and we increased every single time. So really proud of that work that the teams did with that. Next slide. Here's our teams seeing patients in the Delta Dental bus. They parked right outside of Mission. So really happy with that partnership that we had with Delta Dental. And then the next slide. Next steps. And so really it's sustainability of current staff and initiatives. With the grant ending in September, we did see some turnover with our care coordinator for not only funding reasons, but personal. She needed to step away and kind of be more at home. And so we did have a gap for a while with that maternal health care coordination position. We are now getting that back up and going. Our previous care coordinator is still PRN, so she's training the new one up, which has been really helpful. And streamlining workflows. When you are flying the plane while you're building it, you kind of have to take a step back towards the end and be like, okay, what's working and what's not anymore, and then re-educating the care teams on that change. And so that's what we're working on right now. mHelp implementation. This is the baby boutique. This was just getting going towards the end of the grant, and so trying to keep that momentum going, even though we don't have that funding to back it, has been really challenging. But it has been helpful getting our care coordinator up and going. Um, Right, continuing with the car seat checks, with that care coordinator leaving, it's like I don't want to forget about all the things that she was doing at that level. So making sure our staff are educated and that they're following the process, and we are providing that service to our patients. And then continued collaboration at the state level. This has been huge. We have staff that sit on the Maternal Health Advisory Committee for the state of South Dakota, which has a lot of different people from different organizations. Continuing to advocate to increase our Medicaid reimbursement rates. Our state Medicaid also has a Baby Ready program, so it reimburses for extra care coordination services you do above and beyond outside the provider visit, and that has been really helpful in sustaining our efforts. And actually, I think our CEO just testified yesterday or the day before at the state legislature for increasing Medicaid reimbursement. We are very vocal about it. And so just continuing to keep that front center. And then super excited about the state's rural health transformation funds. I don't know if you guys have talked about that in other sessions. South Dakota has a large focus on maternal health and keeping that front and center. And so that is really exciting for us. I think we'll find that extra support for these initiatives so they don't just die. We'll be able to sustain them so long as it aligns with the state, which it does. So we're just kind of waiting for all of that to be, go through appropriations so that funding becomes available. I feel like I ran through that very fast. So thank you.
Thank you, Darcy. You did run through that, but it was very good and so many questions I have for you. And please go ahead and continue asking those questions in the chat. I see one hand raised. We'll take a quick question here. Got Becky Johnson from Clinical
Hi.
Family Health.
Yeah. So I'm in Colorado, and I may have missed the part where you talked about how you got a loaner car seat and
Yeah.
what would you dive more into that? Because that would be so amazing
Yeah.
to try to
And
implement in other places.
yeah, and hope if maybe you have some info on it too. It kind of seemed like it wasn't a well-known program. We kind of just stumbled upon it because we were asking questions and like this is the support that our patients needed. And so we kind of just kept calling people and, collaborating with WIC and Bright Starts and hey, do you know of anybody or a company that does car seat loaners, or do we need to purchase our own car seats under the grant? How is this going to work? And it's actually the state had a program, and so our care coordinator we had to apply. There's an application that we had to go through. The biggest hurdle that we had was, can we install it? And what does that training certification look like? And what is the liability to the organization? For us, we would have had to bring in outside educators from Minnesota for like 4 days to get certified to install car seats. It was very lengthy and just wasn't sustainable if we had staff turnover. So our biggest barrier wasn't so much as like finding the car seats as so much as how are we going to incorporate this into the clinic. And so we were able to compromise and do I think it was a 1 day training, like 8 hours, where the car seat is installed and they go through all the safety checks and make sure it's the correct size for the infant and doing that education with the parents. And so once we got that all set up, our care coordinator, she drives to Pier, and picks up, I can't remember how many she gets in her, she has to take her personal car. We obviously you pay her for that, but our company cars are not big enough for the car seats. And so she stacks her Suburban full of car seats and then takes them down to the clinic. And then there's like a paper checkout process. The parents have to do education and then sign it out. Um, and I can't remember off the top of my head if we get them back. It's a convertible, so it's a big one. It's not like the smaller ones, or where they change in size. So it's the convertible one that they can take right from the delivery and then use
Wow.
it all through toddler.
Wow, that is amazing.
Thank you.
Thanks.
Thank you, Darcy. That's a great example of public health and primary care collaboration. Just something simple like car seats. So with that, we're going to turn it over to Hope to talk about her work and to continue this conversation. And again, keep the chat lively, and we'll have some questions at the end as well. Okay.
Yeah.
Thank you, Darcy. Hope.
Yeah, thank you, Darcy. You did a fantastic job presenting and just sharing the great work that your team is doing. So yeah, I work for the South Dakota Department of Health. I'm the administrator for the Office of Lifespan Health. And really the different programs that fall under my office include the Title X Family Planning Program, and a lot of different grants, such as the Rape Prevention Education Grant. We oversee the newborn screening program for the state of South Dakota. Some of the staff I work with oversee the Maternal Mortality Review Committee and the Infant and Child Death Review Committee, and then the MCH Block Grant, or the Title V grant, which I'm going to talk about on this next slide. So for those of you that maybe aren't familiar with the Title V Block Grant, this is a grant that was established back in the 1930s, I think it was. And it's really awarded to every state to be able to help push forward different maternal child health initiatives. So there's a 5-year, it's run in 5-year funding cycles. So we actually just started a new funding cycle this October. So that means that my staff was able to go through and pick different national performance measures, which is what you're seeing on the slide right now. So we have to do a statewide needs assessment, and then based off of that needs assessment, our staff are able to kind of analyze what is it that the residents of our state are seeing as high priority and high need. Some of them are able to see what the need is voiced from our state, and others they are I can't remember the exact name of it, but they're national nationally mandated performance measures. So for those ones, it was the postpartum visits. That was a universal one that had to be selected. So our women's health director wasn't able to select what her performance measure was going to be. She had to pick postpartum. And then for Shin on the far right, you can also see that that's a universal priority that had to be picked. Otherwise, some of our other staff kind of got to select what their focus for the next 5 years should be on. So you can see we've got the postpartum visits. For maternal health, for infant, it's focused on safe sleep. For child health, we have medical home, and they actually have 2 priorities. So the medical home and then the food sufficiency. Adolescent health, focus on adolescent well visits, and then Shin, like I mentioned, the medical home. And then going over into the next slide, I'm not going to detail all of these strategies out, but I just wanted to give everyone a glimpse of these are the strategies that staff have put in for this next year on how they're going to work on those priorities. So our women's health director is really focusing on looking at different postpartum care plans, trying to determine different patient navigation and telehealth and remote monitoring. For infant, our infant health coordinators focusing on crib distribution and safe sleep education, working with healthcare and social service provider education, and then also caregiver education on what is the safe sleep environment, what should we be doing to prevent having an infant in an unsafe sleep environment. I'm not going to go over all of these, but you can kind of see that they have these different plans in place, and this is really what they're working toward driving forward right now to be able to address some of their strategies. We can go to the next slide. All right, and then shifting gears over to the South Dakota Plan Program. So this would be our Title X Family Planning Program. In South Dakota, we call it South Dakota Plan, which stands for Prepare, Learn, Advocate, and Navigate. This program provides equitable access to quality reproductive health care with a strong emphasis on confidentiality, cultural sensitivity, and informed consent to low-income and uninsured individuals. So through this program, clinics are able to offer sexual and reproductive health services in a judgment-free space to help individuals make decisions about if or when they want to be able to have children. I'm going to jump to the next slide and I'll go into this program a little bit further. So when a clinic signs on to be part of the SD Plan program, there's different services that are offered through this grant. So this is a grant that helps offset some of the costs that clinics might experience when offering these reproductive health services to individuals who are uninsured, underinsured, on Medicaid, whatever it might be. So it's just kind of to help support the clinic to be able to offer these services. So in SD Plan, different services that are covered would be contraceptive services, wellness exams, cervical and breast cancer screenings, STI prevention, education, screening, and treatment, HIV testing and referral for treatment, pregnancy testing, counseling, and referrals, and then just your very basic infertility services. So through SD Plan, it can be really beneficial, not only because it kind of helps clinics financially offset some of these costs that might be lost, but it also has very specific trainings for the staff that are offering the program. So these can be, how to provide unbiased information. It talks about specifically when you have clients that are adolescent clients. One of the, I'll say, perks of a family planning program is that you can see an adolescent without parental consent. So an adolescent could come in, maybe they want to get on a contraceptive option or they want to get an STI test, but they don't want their parents to necessarily know about it. They can get that service through SD Plan without their parents being notified, but the provider is always going to talk to the youth about how important it is to have adult involvement. So whether it's, yes, we can do this test and your parents won't get a bill for this. We still highly recommend that you're talking to an adult about, some of the choices that you're making, and just have that adult involvement. So maybe it's not even that it's a parent that they're talking with about it. Maybe it's an aunt or an older sibling, but really just helping go back into having that adolescent find some support from an adult in their life, a trusted adult in their life. So that's always something that's really beneficial too. Those are all the slides that I had really prepared. I didn't go into a lot of the initiatives, but kind of more just to set the scene of kind of what different grants and team members are doing at the South Dakota Department of Health in relation to maternal child health. But I think I'll be able to share some more insights as we get into questions and discussion.
Hey, fantastic. Thank you so much, Hope. That was wonderful. Hearing from the state maternal health perspective, from the state agency. I'll leave your slide up here for just a minute and see if there's any specific questions for Hope. Any hand raises? I'm monitoring the chat. We're going to jump in and follow up on some of the chat threads as well. So give it just a second. Okay. So to prepare for this discussion, as let's see, looking at the chat, a couple things have come up in the chat. Perhaps some questions about Medicaid advocacy, maybe how we can work together on things like reimbursement for care coordination. What are you doing in your various roles to advocate for better Medicare reimbursement? We saw car seats, a very clear area of opportunity to collaborate or coordinate with state and local health departments who often have the funds or already have existing car seat programs as kind of their way to get people in the door. And telemed is another note I made, but here are some examples we heard from the environmental scan, and we'll open it up for questions here. So in terms of kind of that collaborative, higher level cooperation, there were a couple examples where maybe even with something like WIC, where one person in a CHC was wearing two hats as both the medical director for public health and being in the clinic. And so maybe some of those services like WIC can be more integrated into the primary care setting. And here's another one. We work closely with our public health department for vaccines. So examples of cooperation or overlap. So let me give you a couple other examples, and then we'll continue this discussion. Please add your questions in the chat, and we'll field those to our speakers. Some examples of collaboration you just heard about and what we heard in our scan. Participation on these maternal mortality and perinatal quality committees, doing needs assessments together. Great work from Darcy's group on that assessment piece with your maternal health grant. A lot of that can be done hand in hand with public health organizations as well, as you probably know. So basically the sentiment out there that there's all these great programs, and this is why we're here today, is hearing about these programs so we can learn about them and coordinate with each other. And there were also some talk about how can we break silos. Time's always a challenge, getting outside of our four walls to talk with others about what they're doing, dealing with busy schedules. But basically, I'm going to leave it here and open it up. So we hearing from Margaret in the chat. I've worked with WIC integration, but have hit roadblocks around privacy and information sharing. Any suggestions to our panelists about how we might better integrate WIC in our primary care settings? Any thoughts there?
I'll jump in quick and then hope you can add in whatever from your side. What we have seen in recent years or over the last 10 years, probably a closure of our county health offices. And so the state is still providing WIC services, but they might not have like a dedicated location in that community anymore. What we tried to do is open up, and the WIC nurse is going to come on site and use our conference room. We used to have OB day so on Thursdays it was OB day. Sometimes we had a high no-show rate because of transportation barriers, but the WIC nurse would try and align some of those appointments with prenatal appointments too. As far as privacy or confidentiality between the systems, it comes down to kind of your state laws and how your Department of Health is, do you need an ROI or is that considered continuity of care? And what that looks like for your policy as an organization, that would be something to look into. But we had very open door communication with our local WIC and Bright Starts nurses. And when we were in the loop of what was going on, so were they, and it just made everybody's jobs easier and it provided the best patient care. So that's something that we have done is they needed a place to see these patients because it's not safe to go to their home or wherever. And so open up the conference room and let them kind of hang out for the day. And if patients show up for their prenatal appointment, walk them right over to the WIC nurse if they're receiving those services too. So we did that at a few of our sites.
Yeah, and I'll kind of add in a little bit from the Department of Health side, and just full disclosure that I'm not involved with WIC. That's within a different office, so I might not have all of the clear answers of how it's structured in South Dakota. But I'm thinking, is there the opportunity to have an MOU between your
Yeah.
entity and the Department of Health WIC program? So then there is that ability to kind of share information back and forth. I know that we have a few systems like that set up, so that there is that ability to collaborate a little bit further. And then I was trying to think about something else, and I think I lost it. So I'll just stop there.
Great. Thank you. You're hearing from Becky Johnson that they were co-located with WIC for a period of time. Then they had to close that location. Our case managers still have virtual meetings to help coordinate between WIC, Nurse Family Partnership, and a few other community organizations. So yeah, yeah. So I have a question too, moving to the topic of closures, and we heard earlier about some service closures. And can you talk about how public health and primary care may be able to band together more when there are these sudden service gaps? Questions from the audience about that, or examples of uh, pulling together to address some of those immediate shortages, band-aids, if you will. How are we doing there?
Yeah, I'll go first this time, Darcy.
Go ahead.
So to kind of elaborate a little bit further of something that Darcy had mentioned about how there was a WIC location, in this specific area, and then there wasn't the ability for WIC to be there anymore. The Department of Health here in South Dakota went through a large restructure 2 or 3 years ago now. So that resulted in some of our public health nursing services not being available in specific locations anymore, and then some of our WIC services not being able to be available in locations anymore. And I think, you know, hindsight's 2020, but I feel like there could have been better communication out, probably on the Department of Health side with other entities that we were partnering with on public health services and WIC services to let everybody know, like, these aren't going away. We're still providing a way to cover WIC services in this area, even though we don't have a physical office. And maybe just share the plan a little bit, and maybe even have some meetings or discussions with these partners, so then that there is better understanding of these aren't going away, but it's going to be services are offered 1 day a week instead of someone being there full time. Yeah, so I guess the Department of Health, there was no intention to not be able to offer services. It was just a restructure to make everything kind of have some stability.
And I'd add on to that. So we've had across the state, we've had, I think, two labor and delivery units, like hospital wards, actually close their doors. Patients may still present to the ER and have a baby, but they're no longer staffing delivering providers. And we were very hard hit in one of our areas because of that. And that ties back directly, for the most part, there's a couple different factors, right? Like locums, it's hard to find and recruit and retain experienced providers in high risk areas that they're the only delivering provider. But also Medicaid reimbursement plays a huge role in that too. We see that at the primary care side of things for every Medicaid visit, every Medicaid patient that comes in for a visit, we lose a substantial amount of money. Um, and so that goes to understanding your payer source and how it's impacting your programs and really honing in on that. And that's where I said, like, our CEO is testifying this week at different committee hearings because of Medicaid reimbursement. They were after years of talking to Medicaid, Medicaid agreed to do like an external investigation or assessment to really see what the reimbursement versus the cost is. And so I think that came out in the last couple months. And so just it's slow, but continuing that advocacy, telling the stories, how the impact is. Ourselves, Horizon, we've closed three primary care clinics and one dental office for multiple reasons, but a lot of it goes back to that reimbursement piece, in really advocating for the care that you're providing at that level. So multi-factor, I think, question. DSS is different from the Department of Health, but we all work very, very closely together. as far as that goes, at least in South Dakota.
Great, fantastic. Checking the chat, I don't see new questions, but I do have a question for our panelists about what you have seen, or any of our participants, what you've seen in your states around community health workers. There have been initiatives to expand or to professionalize or sort of develop certification programs for community health workers. And how does that relate with these integrated primary care teams or with health departments? And what's happening in terms of collaboration about community health workers?
I can start. We have a small community health worker program, or we have one at the moment. She's fantastic. We had a few more, but had some staffing turnover. I think South Dakota was one of the last two states in the nation that had a CHW program, and so pretty slow to get going. But in the last 5 years, I think the state, everybody in the state has recognized that how much they bridge healthcare and community resources. And if you get a good CHW, the work that they do. I mean, ours, she's helping drop A1Cs left and right, helping them find jobs and transportation to their appointments. She's just fantastic. Um, I can say from my perspective, it was really exciting to see the Rural Health Transformation Funds come out, and our state made it very clear that they are in support of community health workers. That has a huge role in the funding opportunities. I think their goal is to double the number of certified CHWs in the state by 2030. And so that's huge. I'd love to, I want more in different sites, but also understanding that reimbursement part of it. We can only get reimbursed, I mean, through Medicaid. Medicare you can, but it seems extremely difficult given our patient population and how Medicare billing guidelines are. Um, but really excited to kind of see that momentum go forward, because most of their funding, I think, was lost in the last year, and they were able to advocate and get back on that center stage. So super excited for what's to come for CHWs.
Okay, fantastic. Our time is coming to a close. I think it's a great that we ended on the upside of this rural transformation grant coming. I think it's going to help fill some of these gaps and provides extreme opportunity for public health and primary care collaboration. So I want to thank our panelists. I want to thank Jen and her team at Champs for this wonderful session today. Thank you so much, and thank you to our speakers.
Excellent. Thanks so much. So thanks to Dr. Tallboys and Darcy and Hope, and all of you that shared your expertise and experiences with us in the chat as well. As usual, I'm going to let you know that your opinions are really important to us. So if you could just take just a moment to complete the evaluation survey that's available in the chat right now. And if you're leaving us for this session, again, thank you for your participation today. And if you're staying on for the next session, Strengthening the Foundation, Innovations in OB Care and Workforce Development, you can stay logged on. We'll move you to the Zoom waiting room while we set up for the next session, and then we will bring you back at the top of the hour. So thanks again, and I hope to see many of you in our next session. So thanks again.